It's my pleasure to introduce Dr. Brian Skian, who's the Vice Chair for Education and Director of Child and Adolescent Fellowship Training, who will introduce today's speaker. Brian.
Thank you, Dr. Rothschild. My pleasure to introduce Dr. Ibrahim Sabri, one of our graduating Child and Adolescent Psychiatry Fellows, for his Grand Rounds talk today. Dr. Sabri graduated from the University of Jordan Medical School in 2017 and spent 2 years practicing in Jordan, providing care for refugees and underserved populations. After that, he moved to New York and spent a year at the Feinstein Institute for Medical Research, studying how psychological factors impact patient adherence to care. He then completed his psychiatric residency at Brookdale Hospital, where he worked with people from different backgrounds, gaining experience in treating patients with various backgrounds and challenges. During his residency training, he trained in psychodynamic therapy at New York Psychoanalytic Institute, and during his fellowship, he was trained in trauma-focused CBT here at UMass and regulation-focused psychotherapy. He's completing his second year of CAP fellowship and has been serving admirably as our outpatient chief resident in Community Health Link. We are so pleased, and I'm delighted to hear his talk, which he is well positioned to give, Displaced Lives, Immigration, Identity, and Dynamics of Belonging. Dr. Sabri.
Thank you, Dr. Skihan, for this lovely introduction. I think just before starting, I would like just to say two things. This was a very broad topic. It was really hard just to pick up different topics inside immigration to speak about, especially then with the current political climate going on. We tried our best just to avoid this topic not to be political as much as possible. I here would like really to thank Dr. Raj, Dr. Sitichai for just helping me and supervising me, providing me with different resources and preparing this Grand Rounds. The other thing is that in case you're here looking for numbers for statistics, I really avoided that here because I wanted really to focus here more on how we can approach immigration as a topic, how we can approach immigrants' mental health rather than just speaking about them as numbers. I want to speak about them as persons. So first of all, I don't have any disclosures. The objectives for today's talk is gonna be, we'll try to speak about narrative, try to understand it, try to explore how narrative is and the key factors that shapes it. We'll speak a little bit about immigration, acculturation, and identity. We'll try to examine how migration experiences influence cultural adaptation and identity formation. And last but not least, we'll speak a little bit about what is culturally informed care, what are the different strategies and resources that we can use. So I'd like first to start with a case presentation. There's two different cases that are in this presentation. Both of them are real patients. Some of the information were changed just in respect for the patient's privacy. So first of all, Amina. She was 17 years old, presented with complaints of persistent anxiety, difficulty sleeping, and lack of motivation to attend school. She described feeling overwhelmed and stuck with frequent headaches and fatigue. During the session, she appears withdrawn, avoids eye contact, provided only short, vague answers. Her parents expressed frustration, labeling her behavior as lazy and citing recent conflicts over her academic performance. They attributed her struggles to stress and see no need for mental health intervention. As we can see here, this is a very common presentation that we can encounter with different age group. We'll keep this case for now in our mind and we'll get back to it at the end of the first section. So let's speak about narrative and how does it really shape our identity. There has been multiple definitions if you just go online and try to find what narrative really means. This is one of the definitions that I always rely on just my practice or working with patients. So narrative is a cohesive story that integrates our experiences, shaping how we understand ourselves and the world. Salman Akhtar in his book, Immigration and Acculturation, highlighted narrative as the threads that weave the fabric of identity, connecting both personal history with the present realities and future aspirations. The psychoanalyst Donald Spence, in his book, Narrative Truth and Historical Truth, he differentiated between narrative truth as how individuals interpret their experiences and historical truth, which is the objective facts. So let's remind ourselves here that narratives are subjective, but deeply impactful in forming identity. They are stories that we tell ourselves or inherit from our communities and help us view the world in a unique way. So what are the different key elements of narrative? As I said before, like if you go and try to read or Google anything, there's multiple elements. These are the four major things I felt are related to today's topic. So first of all, it's the experiences that we go through. It's the personal events and milestones as a person that you go through in your life, such as migration or loss, graduation, any kind of role transitions that you go through. There is the cultural context, which is the collective narrative that we inherit from family, society, and traditions. Relationship itself are interpersonal dynamics that influence how we shape and share our stories. Akhtar, in his book, Immigration and Identity, emphasized that the immigrant narratives are often shaped by relational ruptures and efforts to maintain connections to one's homeland. Emotions, as well, is how we process and internalize experiences, and usually narratives often emerges in response to distress or significant life transitions. So how really narrative will shape our identity? Understanding disrupted narratives is crucial for providers to support identity repair and integration. Narratives are integral to constructing identity, helping us reconcile past, present, and the future. Immigration often disrupts established narratives, forcing individuals to renegotiate identity. Akhtar describes this as the mourning process for the lost homeland, followed by adaptation and redefinition. Erik Erikson's theory of identity development suggests that narratives play a crucial role during transitional phases of life, such as adolescence and cultural shifts. So why understanding narratives matters in the end? Well, it will help providers developing empathy in the right context, as narratives provide insight into how individuals perceive their experiences, helping clinicians see beyond symptoms. Healing can happen through stories, because listening to and reshaping narratives fosters self-cohesion, a key concept in cohort self-psychology. As well, immigrant narratives important, as it is essential to understand the duality of both belonging and alienation experienced by immigrants. And cultural sensitivity matters because each narrative carries a unique cultural, historical, and relational layers that require nuanced care. So if we go back to Amina's case, here I want to emphasize on something that when we worked with her for some time, she engaged in therapy on a weekly basis, and we were able to create her own narrative. I would like to emphasize here that we prescribed medications. We didn't only rely on therapy. We did prescribe medication that helped her to become more mellow and being able to participate in sessions. So the point is always to remember that it always needs to be a biopsychosocial approach. So if we look at her own narrative now, she has been struggling between two worlds. She was 17 years old who fled from Syria with her family after war made it unsafe to stay. They arrived in the United States seeking safety. But Amina quickly realized that survival wasn't just about escaping violence. It was about rebuilding a life in a place that felt completely foreign. At school, she struggled to keep up with her classes. Although she was an excellent student back home, the language barrier made her feel incompetent. Teachers spoke too fast. She hesitated to ask for help, afraid of looking stupid. She often sat alone at lunch, watching groups of students laughing together, wondering if she would ever belong. At home, her parents reminded her that she was Syrian first. They expected her to speak Arabic, dress modestly, and avoid American habits they feared would change her. But at school, she felt the pressure to fit in, wearing different clothes, speaking fluent English, and hiding parts of her culture to avoid standing out. This constant push and pull left her feeling lost, who she's supposed to be. The stress took a toll on her mental health. She started having panic attacks before school, dreading the feeling of being invisible. She lay awake at night, replaying awkward conversations in her head, feeling like she didn't belong anywhere. Even her body seemed foreign. She no longer recognized the girl in the mirror, caught between two identities. One day, a teacher noticed Amina's withdrawn behavior and suggested she see the school counselor. But Amina hesitated. Back home, mental health wasn't something people talked about. Seeking help felt like admitting failure. She wondered, would they understand my struggle, or would they just see me as another immigrant trying to adjust? So our intervention plan, as I mentioned, like we prescribe medication, work with her on a weekly basis, but our therapy focused on like fostering belonging. And we did that through, first of all, like cultural identity support. We created a safe space where Amina can celebrate her Syrian heritage while exploring new cultural experiences through participation in the different cultural clubs or community events that bridge her past with her present in the community. Also, we connected her with a peer mentor who had a lived experience like her. We made referral for a group psychotherapy for immigrants, and we're able to connect her to different social support groups for immigrants through the community center. We focused on the extracurricular engagement. We worked her in like identifying her own interest and connect her to the places that I provided that. She was interested in art, so we were able also to engage her in art therapy, where like she was able to express herself more. We also collaborated with the teachers and like school counselors. We made sure they have a good like cultural understanding, and most important, like we involved family in our discussions and they tried to bridge the gap between the two cultures. So as mental health providers, we try to address the different maladaptive behaviors within the cultural norms that the family is embedded in. But we have to be careful that we don't impose our own cultural norms on our patients. So let's move here for the next part, which is like the immigration, acculturation, and identity. So we'll start another time with a different case. So Sophia is a 35-year-old female who immigrated from Venezuela 2 years ago. She presented to the clinic with complaints of persistent fatigue, trouble sleeping, and feelings of sadness and hopelessness. She described feeling disconnected from herself and overwhelmed by the challenges of her new life. Once a respected teacher, Sophia now works as a cashier, a role she feels is far below her qualifications, which has left her struggling with a diminished sense of purpose. She mentions avoiding social situations due to self-consciousness about her accent and feels isolated, as her husband and children are busy adapting to their new environment. Sophia reports constant worry about her ability to support her family emotionally and financially while grieving the loss of her close relationships and community back home. Her symptoms include a depressed mood, social withdrawal, and frequent anxiety about her role as a mother and her identity in a foreign cultural landscape. So we'll keep the case, we'll come back to it another time. So let's speak a little bit about the concept of belonging. There's like different definition of it. Like this is one of the definitions I felt like is good. Like belonging is the intrinsic human desire to be an accepted member of a group, community, or society. It encompasses feelings of security, acceptance, and identity affirmation. It involves both relational and cultural dimension. Relational, which is the connection with others, and cultural, which is the shared traditions and values. And if we look at Maslow's hierarchy of needs, we can see that belonging is a fundamental psychological need that is positioned exactly after safety and the physiological needs. So disruptions of belonging during immigration will impact mental health and identity stability. So immigration itself, like it can be thought about as a multi-phase process. It's like involves both the physical relocation, but also profound psychological transitions. When it comes to the different like stages, there's like the pre-immigration, there is the immigration stage, and there's the post-immigration. Each one has a different factors that will affect it. So if we think about the pre-immigration stage, the first thing will come into our mind is the motivation. What was the reason they decided to move, to relocate, even if it's within the same country? Was it because of war? Was it because of persecution, economic instability, family reunification? Or was it even like their own decision, or was it like someone else's decision? Did they decide where they want to go, or someone made that decision for them? Then there's the psychological impact per se of the idea of immigration, which is like the anxiety about the unknown, the mourning of the anticipated losses for the different relationships, familiar environments, etc. There is the pre-immigration stress, sometimes can lead to what we call is anticipatory grief, that sometimes is under-recognized. Then there is the immigration stage itself. There is the experience of the transition. There is a physical and emotional dislocation. There is exposure to different discrimination or systemic barriers during the process of a transition. Freud spoke about this back like in 1917 when he spoke about melancholia in the immigrants. And he said that it's a response to loss where the ego simply internalized the lost homeland. As well, Actor in one of his books speaks about immigrants who are trying to navigate the trauma of uprooting, losing psychic anchors such as language and familiar customs. And then there's the post-immigration stage itself. There's the acculturation stress here. They're going to try to navigate the different language barriers. There's the cultural dissonance. There's the integration challenges. There's the adaptation challenges as well, building a new relationship, reconstructing identity in a new cultural context. So, as we said, immigration is a psychological journey. It's experienced as a multi-layered stress response influenced by personal, cultural, and systemic factors. Salman Akhtar speaks about this and tried to mention like the different 6 key losses that an immigrant will experience. There is the loss of homeland, there is the loss of language fluency, there is the loss of social structures, loss of status, loss of identity, and loss of belonging. Frantz Fanon, in one of his books, speaks about immigration as a form of existential alienation, compounded by systemic racism and marginalization. Well, like in the end, psychological cost of immigration stems from the disintegration of a pre-existing identity frameworks. So there's different theories of acculturation and identity formation. Identity, here we need to remind ourselves, is that continuously renegotiated across cultural transitions and across different stages of life. When John Berry's acculturation model, he speaks about different stages, which are assimilation, simply replacing one heritage with the host culture. There is the integration, trying to balance the 2 cultures. There is the separation, rejecting the host culture. And there is the marginalization, which is rejecting both cultures. Stuart Hall cultural identity theory tries to explain identity as a dynamic, evolving process shaped by cultural interactions. And immigrants often create hybrid identities, integrating elements of both heritage and host cultures. And as we mentioned before, like in Erik Erikson's identity development, immigration heightens identity crisis, particularly in adolescents who must reconcile their heritage with societal expectations. So, Edward Said in his work Orientalism spoke about immigrants are often othered, leading to exclusion and devaluation. Pierre Bourdieu in their work Social Space and Symbolic Power speaks about symbolic violence, which is cultural systems devalue immigrants' identities by privileging dominant norms. On Fanon's alienation theory in his book, Black Skin, White Masks, immigrants usually face what we call double alienation, which is simply disconnected from their homeland and marginalized within the host culture. So if we take a moment here and think about what Frantz Fanon is trying to speak about, is simply colonization causes the oppressed person to internalize a sense of inferiority. Over time, the internalized oppression may drive them to immigrate, a process that inherently is stressful per se. However, upon arriving to a new country, they will encounter additional social and systemic barriers, leading to a sense of double alienation. This feeling of is intensified in environments that unfortunately have some kind of an implicit oppressive structure and reinforces the notion that the immigrant is always going to be the other. So, resilience is fostered by reconstructing narratives and creating inclusive environments. Healing sometimes emerges from the intersection of the personal narratives and culturally attuned care. Michael White's in narrative therapy, usually they work with immigrants to reconstruct their life stories, to restore coherence and meaning. And in cohort like self-psychology, usually immigrants, they need what we call self-objects to repair disruptions in self-cohesion. And usually self-objects is simply just an internal representations of how their life they want it to be. And that will be the different cultural rituals, the supportive communities they're looking for. So if we go back to our case, Sophia, she was trying to reclaim her identity and belonging. So in the pre-immigration, she experienced anticipatory grief over leaving her parents, close friends, and the professional life behind. There was anxiety about the unknown, including financial instability and cultural dislocation. During the immigration process itself, there was the language barriers, there was the self-consciousness about her accent, leading to social withdrawal. There was discrimination and systemic challenges which reinforced feelings of inferiority. And if we think about it through like Fanon's like alienation theory, she simply internalized oppression, which left Sophia feeling invisible and undervalued. In the post-immigration stage, there was the loss of professional identity, creating a sense of purposelessness. There was isolation as her husband and children adjust to their new lives, leaving her without emotional support. As well, she was torn between preserving Venezuelan traditions at home and helping her children integrate into the American society. So, Sophia experiences disconnection from both her homeland and host culture, intensifying her feelings of loss and invisibility. She struggles with the loss of homeland, status, social networks, cultural fluency, leaving her identity fragmented. Sophia lacks the self-objects that affirms her identity, such as the community or cultural connections, which are essential for self-cohesion. And then Sophia's internal narrative focuses mainly on loss and inadequacy. Trying to reframing her story could highlight her resilience and adaptability. So our treatment goals with her focus on different things. We tried to rebuild like her identity. We helped her enrolling in what is called like career boost through the community center. She was able to attend art therapy classes at the community art studio and worked in finding different professional groups at the Meetup application that any one of us can actually download. We helped her restoring the feeling of belongings through like attending weekly meetings at a local Venezuelan community center, helped her participate in events like Venezuelan heritage festivals. She joined a language exchange group called the Speak Up Cafe. And we worked as well in like reconstructing her own narrative and trying to focus like how it showed actually resilience and flexibility instead of loss and inadequacy. And most important is family engagement, where like helped her organize monthly family dinners through like with a Venezuelan theme, as well in some of the appointments, her family were able to join and share their own part of the story. So here, like, we'll talk a little bit about like how we can actually provide a culturally informed care, which is, I'm pretty sure a lot of us is really providing that, but sometimes just having a good framework in your mind, you can start picking on different things that maybe you are like missing in your care. So what is culturally informed care? It's simply incorporating the patient's cultural background, values, and experiences into the mental health treatment, ensuring it aligns with their worldview, not our worldview. It has different core principles. Mainly. It will include cultural humility, which is a lifelong process of self-reflection, curiosity, and adapting to diverse cultural identities. It needs to include both like empathy and respect through listening to and valuing the cultural differences without judgment. It will include collaboration with the patients and their families to co-create care plans that honor cultural practices and beliefs. It needs to have also an element of a trauma-informed care because, as we mentioned before, immigration itself is a psychological journey. So culturally informed care will foster trust, reduces disparities, and enhance patients' outcome. There are different models that you can actually like use during like providing that kind of care. One of them is the LEARN model, which is I got like trained in when I was like during residency, so I know it the most, which is simply a 5-step framework to foster culturally attuned communication. It stands for like listening actively and empathically to the patient's perspective without interruptions. Try to explain and offer a clear culturally sensitive explanation of the clinical observations and diagnosis. Try to acknowledge and recognize the differences and similarities between your perspectives and the patient worldview. You need to try to recommend and or your recommendations need to align with the patient's cultural values and beliefs. And you try to collaborate and negotiate in order to create a mutually acceptable and effective treatment plan. So usually it builds on a trust and ensures that the care remains relevant to the patient cultural context. Other models that you can also practice, there's the ethnic model or the respect model. The ethnic model mainly emphasizes on like using what we call cultural healers and interventions. It stands for explanation, treatment, healers, negotiate, intervention, and collaborate. Or there's the respect model, which is widely used to promote physician awareness of their own cultural biases and to develop physician rapport with the patients from different cultural backgrounds. It has 7 core elements, stands for rapport, empathy, support, partnership, explanation, cultural competence, and trust building. So there's like different strategies in order to provide this kind of like culturally informed care. Like tailoring care to each patient's cultural framework will promote therapeutic engagement and empowerment. What really matters is that you need your patients or your client to feel empowered, and then somehow they are the person who is dictating their treatment plan. That should be always our goal in the end. So it comes through like assessing the different like cultural context. There's like different resources that you can use, like the DSM-5 cultural formulation interview in order to explore the patient's cultural identities and experiences. You can also integrate a culturally relevant assessment like the explanatory model of illness. We can always adapt our interventions through like modifying the different therapeutic approaches like CBT, narrative therapy, in order to reflect the cultural values of our patients. We can address the cultural stigma surrounding mental health through education and normalization. And definitely improving the language access through like providing interpreters and culturally translated materials, which is unfortunately sometimes we lack. A lot of our questionnaires that we use or like materials that we have sometimes lack the translation for some languages. Avoid using family members for interpretations in order to preserve that kind of confidentiality, although it's easier when like the parents is there for sure, but somehow you need to empower your patients through like using an interpreter and let them take control over their own like treatment. We need to recognize the different systemic barriers. We need to understand that there is discrimination, there is a socioeconomic challenges, and the immigration status will affect their mental health. And through like as well like community collaboration, through like partnering with the different cultural organization, community leaders, and faith-based groups to extend the culturally relevant care. So other resources that we can always rely on, as I mentioned, the cultural formulation interview through like the DSM-5. There is the national CLAS, which is through the Department of Health and Human Services, and this stands for like the culturally and linguistically appropriate services. There is a book through Cambridge called the Ethnopsychopharmacology. They try to update it every like 2-3 years. It's like an ethnopsychopharmacology advances in current practices, where it actually speaks a lot about the herbal medications that some of our patients will present with, sometimes from their own like cultural like background, and that will help you understand how it may actually interact with the different medications, or like is there like actually any rule for it or no. And through UK as well, following their like NICE like 2008 meeting, there was a practical guide for healthy professionals, which is labeled as community of engagement with locally Black and minority ethnic community groups, which emphasizes the importance of healthy professionals collaborating with cultural brokers and community leaders to bridge cultural gaps and enhance healthcare delivery. And as we mentioned before, there's like the language line solutions. We have like, some of them have like professional medical interpreters, which is like 240 plus languages. Something I learned recently in the ACAP, like I speak in a different language, I speak in Arabic, but actually I will need to do a specific kind of exam in order to provide care in Arabic, just to make sure that I'm able to like speak in the right medical terms that the patients need. So that's something, if anyone speaks another language, you need to keep that in your mind. There's the different, like sometimes we can use different like interpreter agencies, like which like tailor to specific community needs. And there's multiple organizations that we can get connected with. There is the like NAMI. If you just Google like NAMI, resources for diverse and populations, you will have like multiple resources for different like patients with like different like populations, different backgrounds. There's the Refugee Women's Alliance, culturally specific support for immigrants and refugee women. There's the National Center for Cultural Competence. There's the Refugee Health Technical Assistance Center, and there's the Society for the Study of Psychiatry and Cultures. Some of the books that are really relevant to this kind of topic are, like, as I mentioned, like about like Salman Akhtar's book, Immigration and Acculturation, where he tried to explore the different psychological and emotional journey of immigrants as they navigate mourning, adaptation, and cultural transitions across generations. There is the trauma-informed psychotherapy for Black, Indigenous, and people of color, where they try to decolonize the approach to mental health through offering a trauma-informed therapeutic framework that addresses the unique challenges faced by these populations. There is as well the Clinical Manual of Cultural Psychiatry, which simply provides a mental health professionals with essential insights into cultural psychiatry, helping them offer more effective and culturally competent care. There is also Culturally Responsive CPT, which is a book that integrates the cultural consideration into CPT, offering a practical guidance for therapists working with diverse population. More books is like, there's The Myth of Normal Trauma, Illness, and Healing in a Toxic Culture, which is through like Cabermati, where he challenges the conventional ideas of health, trying to explore how the societal pressures, trauma, and inequality contribute to illness, and offering insights on healing in a disconnected world. There is the First Crossing, Stories About Teen Immigrants, which is actually a very good book. It's about like 10 different immigrants from 10 different backgrounds, written by 10 different writers. And each one of them explore the different kind of stressors they go and their like transitions. And the nice thing about this book, after you finish it, if you Google it, there's like a blog where they discuss each story in a different way. And there is The Spirit Catches You and You Fall Down, is like Annie try to examine the clash between the Western medicine and the Hmong cultural beliefs through a true story for a Hmong child with epilepsy, highlighting the challenges of the cross-cultural healthcare and the importance of cultural understanding. If you're a person who does not like to read or does not want to go into different resources, there is multiple TV shows that and somehow delve into these kind of issues. There's the Little America, which is simply a TV shows on I think on Apple TV, where they simply they showcasing the struggles and hopes of different immigrants from diverse background. The nice thing about each episode is about different immigrants from a different background. They try to speak about the first generation, the second generation. Are you did you immigrate or your parents? So it's a nice show. There is Mo, which is about a Palestinian refugee in Texas, where he tried to navigate life between two cultures while awaiting asylum and trying to balance family. The nice thing about this show, it delves more into our immigration system here, and it shows you some kind of the arbitrary ideas that we have here, which is something I learned I was not aware of, that you can actually be deported but still living in the US because you're stateless. That's one of the things I was that's new for me. And you don't have to be in an ICE detention, but when you are outside, you can't actually work or do anything. Another thing was true when I was just reading about the immigration is that ICE have the right to put an ankle monitor on you. And through that ankle monitor, you need to communicate with them. They have access for they can listen for you. They can look at you all the time, and you need to respond to them in a timely manner. And unfortunately, as well, they can listen for everything you're doing in your life. So there's no privacy. And the way these ankle monitors are chosen for people are very random. They will put 10 people, okay, we're gonna give it to number 7. There is no really reason why they chose that person, just you're number 7. So you end up having to wear that monitor. Then there is another show, Unorthodox. It's about a young Jewish woman who flees the ultra-Orthodox community in Brooklyn and an arranged marriage, and try to go to Berlin in order to try to discover her own identity and freedom. Other shows are really interesting. There was Stateless, which is about both immigrants and non-immigrants. It's about people who meet in an Australian immigration detention center, where they actually grapple with both displacement to try self-reinvention in an unfamiliar world. There's Rami, which is first generation Egyptian American who try to juggle between both the religious devotion and the personal desires in a cultural family. And there's One Day at a Time, which is about a Cuban American single mother who is actually a military veteran, and she tried to raise her children while dealing with cultural traditions, mental health, and family dynamics. So my takeaway home message here is this, is that our patient doesn't come in a vacuum, we like it or not. There's multiple intersecting factors shape their experiences, struggles, and identity. Your patients may be an immigrant. They will be coming to you. They're listening to the news, and suddenly there's a new executive order being signed. That will affect them. Do you discuss it or no? I personally really don't know. I tried like to find a good resource for that. I do feel like this is more comes from experience. You will be able to know and draw the line. The cultural context really matters. There is the patient cultural background. There is your cultural, like your culture and background. And there is whereas the clinical setting is happening, that's culture and the background that you need to take into effect. The narratives will shape the identity, and understanding a patient's story is key to providing compassionate and effective care. And a culturally informed care requires both humility through like listening, learning, and adapting our approaches to meet patients where they are, not to expect them to meet us where we want them to be. And belonging is a fundamental for well-being. Mental health care should foster a sense of connection, agency, and self-cohesion through empowerment. And I think one of the other things that I didn't put like here, like on the slides, is that there is a nice book. It's called like The Perspective of Psychiatry. It's like an old book, I think in the 70s, through like two different psychiatrists. One of them, I think his name is Ball, where like they discuss about like how to approach psychiatry in different in a four-dimensional way, where like there's the disease, there is I think the social, there's the psychological, and there is the life narrative. And I feel like that's kind of a book that personally during my residency, when I encountered, that was very helpful for me just to shift my whole thinking. Because we can't deny that currently our training focuses on us as on like biological interventions, and the other things is just like, it's by default, you will learn it. It's like, it always goes like that. I feel like that kind of a book should be somehow part of like the curriculum for like any residency program. These are the different like resources that I really use for today. I know it's a short one. I tried my best. And as we always say, what you need in trying to help people are the qualities of a good bartender: sympathy, willingness to listen, and intuition. Thank you.
Thank you very much. People on the Zoom, please type your questions in the chat.
Well, thank you so much, and good effort on presenting and summarizing such a very deep and wide topic. I have two questions, and I'll ask them in order. I want to hear your thoughts about the first one, and then I'll ask the second one. I want to go back to the first case, Amina. You don't have to go back with the slides, but just is it the 17-year-old refugee from Syria who's struggling with alienation, cultural acculturation issues, the harborings of immigration. And I want to unpack a decision you made there, or maybe challenge it to medicate that young girl. And first of all, I'm always wary about medicating what does not necessarily need to be medicated. I mean, we did not hear much about her history, so there's a lot left unknown. Did she see war firsthand? Is she traumatized? Are there traumatic reactions? That maybe warrants medicating. But not only that, I think the decision to medicate really cuts deeply into the narrative question, because I can imagine this young girl leaving your office thinking, okay, well, my psychiatrist gave me this pill, hence, am I crazy? And going back home with a bottle of medications, what would her family think about that? So the whole question of reconstructing narrative could be really at the core of that kind of decision. So I really want to hear your thoughts about, how do you approach that with a case like this? How did you approach it? If this is a real case, and you ended up medicating her, which I can understand. I mean, sometimes we need to medicate someone who's their anxiety, regardless of the source of it, is really interfering with their ability to function. But as the topic of today's grand round was this kind of personal, subjective narrative, how did you navigate that with her, and what was the discussion or the recommendation process was like?
No, it's a really good question, and definitely when she presented, there was a lot of trauma-related symptoms that we can simply relate, which is, as we mentioned, that immigration itself is stressful, can become a very traumatic experience for a person who's 17 years old, already going through different transitions in their life, just becoming from an adolescence. In a year they will become an adult. With her, we did start with therapy. We did not start with medication. I always go with this. I prefer to try therapy with them. And I was like I was lucky to have a supervisor with me because I did the therapy. I worked with her during my residency while I was like doing actually adult psychiatry. While I was working with her, we would like have like some kind of improvement for like maybe 2-3 sessions. You try like to work with her like about the different stressors, but then there is another decline because there is a different stressors is happening at the school. So we reach a decision with her is that like I start feeling that she's somehow not mellow like in the appointments and is very stressed out, that I need something just to like bring her like fight and flight down in order for her to be able just at least to participate in a session for like 45 minutes. So like after time, the good thing is like about this case, for example, I'm coming from like an Arabic background. So like I understand her stigma, I understand her family's stigma. So that, and somehow that helped me. With the other case, just like briefly, like we ended up also giving some kind of medication. I had one of my attendings who was actually from Venezuela and like helped speaking with the patients. So I feel like in these kind of cases, when there is a stigma around medication and like you really feel like in your judgment that medication is essential. I need to do therapy, but I need also some medication to help person to calm down. I do think we should always like seek help from people who share the same background with our patients. And there's a lot of them, at least like when I worked in New York, that was like one of the things that for me, I always like, even it was just like a nurse or like even like someone that I can just try to find some kind of understanding. So I ended up like prescribing the medication for like her with us. We started her on like an SSRI and as needed like atarax, but eventually she became really good and she did request to go down on the SSRI and stop it, but keep the atarax as needed. And I respected her decision. Do I really agree with it? It's not about me agreeing with her decision. It's about me trying to empower her, make a decision by herself. And in the end, like I know we developed that kind of proper with her that in case she needs to go back in the medication, she will like tell me and like we will just restart medication without any issues.
Did you see any pushback in any of those two cases or in your cases of immigrants that you prescribe medications about? Yeah. And how do you kind of navigate that?
Yeah, definitely there's always like a pushback. I try like to meet the patients where they are really. I always like try to understand, okay, why you really don't want the medication? Okay, is it because of 1, 2, 3? I try to change the way I present the medication to them in a way that like reflect their like cultural beliefs. Like some of people, like at least in like the people that I work with, like one of the patients like tell me, no, like this medication, like I think a lot of us encounter that will make me like addicted. Like I try to navigate that with them. Usually like these kind of like cases are like where like I personally, when I have like I get stuck, I try to find someone who share really the cultural background and try to help me like, okay, what are the different approaches with this person?
So my second question, sorry, I took much time, sorry. You also made another decision I want to challenge a little bit, which is not to engage with the political situation right now. I mean, this topic is really very salient right now. I mean, I'm an immigrant and I feel at an existential crisis living in the US right now. You know, somebody with, I'm not a citizen yet. I'm still on a green card. And so, and you also mentioned that you are, you know, struggling to know whether you approach back with your patients or whether that's something to, I mean, in my, you know, in my opinion, when we are fearful, we have multiple options. Certainly we can withdraw, you know, but we can also engage. And I thought this would be probably the perfect place for a scholar like you to kind of engage with what's happening. So I want to know, why did you choose not to, and why not to, you know, unpack this, you know, in front of your colleagues and kind of say, this is really, you know, a very difficult time, and it kind of cuts into our own personal narratives, which makes us also in retrospect think, did I make the right decision of immigrating to this country? I don't know, you know, so I want to hear your thoughts on that.
So no, it's actually very good. And I can tell you because we share both, like I'm also an immigrant myself. So I was like in the beginning really reluctant about like even just speaking about the topic, because as you said, like I'm an immigrant myself. Maybe I'm here like legal, you know, but like, for example, when you receive an email like telling you, oh, you're on this kind of visa, like 1, 2, 3, you need to keep these kind of documents. These kind of fears like get triggered in me, and I was not like aware like, okay, how I can navigate it. So I felt like since I'm really not like experienced in this topic, I will try my best really to avoid like as much as possible. In the end, you can't avoid it. And like, just like I seek like supervision with one of my attendings who was an immigrant himself, and then like he ended up being like a citizen and everything, and like we were able to do it. So that was like really the main reason, nothing else.
So while I walk up there, I don't know if you know Dr. Tracy Goodness, but she's giving a talk tomorrow in the Mass Psychological Society, and she wants to use your slides.
Okay, yeah, I'll be more than happy.
All right, I'll chat. I'll text her in the chat.
Okay.
Thanks for giving this talk. It was really great. As you were giving your two examples, I found myself thinking and wondering how these two individuals found their way to mental health care. And then kind of more broadly, imagining that, with it being so hard for even people who have grown up here to access mental health care, I can imagine that it's just even that much more challenging to someone who has just immigrated here. So my question is, what are your thoughts on pathways for immigrants to finding mental health care and what we can do to make that easier?
I think if you're really interested in working with immigrants, if you go to community clinics, there's a lot of them there. How they reach out there, unfortunately, a lot of them reach a point where they either commit suicide or they end up being hospitalized in order for them to understand that there is a mental illness that I need to approach. So that one of the things that I personally like working in community clinics because of that reason, because I will be able to find the population that I like to work with. That doesn't mean other clinics, they don't have it. If you go into private practices or universities or anything, you will be able to work with them. That was one of the things that I feel is helpful. Another thing is that if you actually look into the different educational institute around you, a lot of people that are interested in immigrants' mental health, there will be a clinic for mainly just immigrants that people get referred to. For example, here there's the asylum clinic in UMass that you can get engaged with, and you can start seeing people. You see them for asylum, that's one thing, or for medical reasons. But when you start seeing them for medical reason, if you really feel there is some kind of maybe mental health need for them, you can just simply try to refer them to someplace else. Usually this is how we get most of the referrals. Some of them, they already coming from a good academic background, coming here to this country. They already know that there is mental illness and I need to continue. We're lucky with these people, but some of them really gets referred through PCB because the PCB really tried with them all kind of resources and they didn't work out, and they do really believe there's a mental illness going on.
Thank you for a wonderful talk and a lot of resources that I think would be really helpful. One question that I have, it's come up, and we may not have an answer for it, but it's come up a couple of times in the last few weeks, is in more acute cases. So you described some ambulatory cases that I think make sense with the narrative and the identity formation. Acutely, this is becoming even more so in the last 8 weeks, a challenge where people are fearful of getting treatment because that means putting their name on a record. And depending on how their documentation is lined up, I know myself, I really struggle with when someone is scared of being deported if they get treatment, or not getting treatment and being unsafe, is a real conundrum. And I don't have answers yet, other than on a case-by-case basis, trying to figure out how we can negotiate some of these cultural differences. But a lot of their safety concerns were even on the idea of not being able to stay here, whether they wanted to or not.
I think I will be honest, I really don't know. All I can tell you, I shared the same thing yesterday in our a clinic. One of our patients, actually, it's not even just mental illness. Mom is refusing to get an IEP for her kid because apparently we really don't know even if they're documented or no, but she was able to share that. I don't want that to happen. Then the ICE will come and then we're going to start questioning me and all these things. So I do feel in the end, it's really case by case. I really don't know how, especially with the current climate, how things are. Every day you wake up, you read something new and you'll be like, wow, what's going on? So.
Ibrahim, thank you. That was really wonderful. So I wanted to share a little story and then I have a question for you. And my story is that I just remember walking through the passport control when I was a resident and still on a visa, and I had two babies who were born in the US, and the person there said, "Oh, these are your anchor babies." So I'm just, I think this is not a new experience, and it really does bring a lot up. The two examples, the clinical examples that you gave, in both situations, you and your supervisor had a connection, a cultural connection to the patient that made it perhaps easier to sort of navigate that conversation. And the advice you gave to seek somebody in the team that can do that for you, whether it's the interpreter or anybody else, is really great advice, but it's not always possible. And so I don't know if in all my years of doing child psychiatry work, all encounters are cross-cultural. And I always have to actually just be curious because I have no idea what's going on in anybody else's family culture. And sometimes you don't get that opportunity, right? Like I'm thinking a few weeks ago, we had parents who were both fluent in English with absolutely no accent, but both arrived at the US from an African country. And so not asking about how that impacts their parenting or the languages spoken at home and all that doesn't make sense. And there was no way we would get to that through an interpreter, right? Because it really, with those sort of educated people, sometimes you don't even have that opportunity to get that, right? Like it's all covered and you don't even see it. So thoughts about what to do when you're not so lucky to actually have that ambassador right there for you.
I think like for me, I can like recall at least like two patients I work with like in residency, similar to that, where like families were like really fluent. Was one of the patients is actually from China, was like really fluent patient. She was an adult, but she was still living with her family. And we spoke in English eventually. But what I did eventually is that when I start feeling there is something missing in the narrative, I feel like there's something else, I start asking, who else lives there? Or like, who do you usually spend your days with? And they were able to get connected to other family members. So we were like, they did not like speak English or they were not fluent, and we were able to speak more and then like to use interpreter. That was like one of the cases I personally like encountered. Another patients I had as well. So that was like one of the things we did. Another patient that we had, she was actually from Haiti. She was fluent in English. Family is not speaking English at all, but she's an adult presented with psychosis. And the only thing she would say like voodoo, voodoo, voodoo. And like, we were like, I was like, first time for me to hear that. But eventually when like, we will like Google it and we find that we actually asked when, I forgot what it's called, like the priest in voodoo, but we actually got connected to someone like in the community and asked them to come. Although the patient speaks English, but they help us just like to find that kind of connection with her and like with her family in order just like to treat her, because in the end, she believes in voodoo and we need to respect that. But as well, on the other hand, we can't deny our like a clinical impression that there is psychosis going on that we need to treat. So that was like another thing we did.
All right, thank you very much. Very interesting.